All right, guys, let's get busy talking about our eating disorders. I want to start off by saying that classically on step one, these questions are going to be written about a female patient, but that does not mean it doesn't affect male patients as well. This is just classically how it's presented on the exam. Let's get busy starting with anorexia nervosa, which is going to be characterized by an altered perception of one's own body habitus. So people usually look at themselves in the mirror and they see themselves as overweight when that may not truly be the case. So they have altered perception of body habitus. This leads to a fear of gaining weight. And when they're afraid of gaining weight, they're going to lead to behaviors that are going to lead to low body weight. So, this can be a variety of behaviors, and we will go into the specific types in a little bit. Importantly, in all psychiatric illnesses, we have to note the timeline. So, this is greater than or equal to 3 months duration of one of two types. So, let's start by talking about binge/purge type. And this is what happens when patients engage in binge eating, followed up by purging activities. So, we have binge eating and then self induced vomiting, laxatives, or diuretics. So, you're going to hear about a patient who overate and then they compensate by making themselves vomit. Or classically, you may hear of like a nurse who's pocketing laxatives from her patient in the hospital, and then she takes these laxatives herself in an attempt to keep her weight low. Now, we also have the restricting type, which is characterized by dieting or fasting and excessive exercise. Basically, anything that's going to keep these patients in a caloric deficit so they can keep their weight low. That is what is characterized as the restricting type. Now, both of these types are going to be characterized by a BMI of less than or equal to 18.5. I cannot stress how high yield this is. They love to ask about the BMI cutoff for the difference between anorexia nervosa and bulimia nervosa. So this is a number you definitely want to have committed to memory. Also, we talked about this classically affecting women, but it can happen to men as well. So let's move on now to talk about some of the complications. So, of course, we're going to have nutritional deficiencies if you're not eating enough. This can lead to things like osteoporosis, hypothyroidism, amenorrhea, because patients are not getting the nutrients or the caloric amounts that they need. Now, let's also talk about lanugo. What is lanugo? Lanugo is when patients develop a fine hair pattern growth all over their body. So they have this fine, kind of dusty, angel like hair all over their body. These hairs are so light, they're almost transparent. And the reason why these patients grow these hairs is because they are consistently hypothermic. They have low body temperature because they have low body fat reserves. And this is their body's attempt to try and keep temperature high by growing a small layer of hair over the entire body, which I think is pretty cool. So that's something else we'll be looking out for in terms of patients with eating disorders. Now, let's talk about refeeding syndrome, which is going to be a classic presentation on step one because they get to test about some really cool pathology and physiology. So, when we nutritionally rehabilitate our anorexia nervosa patients, they get this big influx of calories that they are not used to. This leads to a big increase in insulin as the body is pumping out insulin in response to this new onset calories. Now, this leads to intracellular shift. So, shift into cells of things like potassium, magnesium, and phosphate. Now, if all of these electrolytes are shifted intracellularly, this is going to lead to seizures, dysrhythmias, and rhabdomyolysis in an acute setting. So if you see an up-down arrow question with some electrolytes, perhaps a patient with a seizure who had an eating disorder, refeeding syndrome needs to be at the top of your differential because it is classic here. In terms of our management, our nutritional rehabilitation is important. We don't want to give someone 2,000 calories in a day who's been used to eating maybe 500 or 600 calories a day because we have to be aware of refeeding syndrome. Also, we want to do psychotherapy with these individuals to help them with their body image issues. We can prescribe olanzapine, which is a antipsychotic that can help people gain weight, as well as do a suicide risk assessment because these individuals are at high risk of suicide. Additionally, in terms of antidepressant or antipsychotic therapy, we want to avoid bupropion because this is an antidepressant that lowers the seizure threshold, and these patients already have an incredibly low seizure threshold, so we want to avoid bupropion in anybody with an eating disorder. That is a high yield fact that may come up in a question step. Let's move on to talk about bulimia nervosa, which is another eating disorder. However, it is characterized by recurrent binging and purging weekly for greater than or equal to 3 months. Now, This is important to differentiate from anorexia nervosa based on the BMI. It is usually normal or low, and it is not going to be severely low below 18.5 like we saw in anorexia nervosa. Additionally, this is more likely to affect women, although it can affect men as well. Now, let's talk about some of the complications, specifically those related to the excessive vomiting in these patients. So, we're going to have Mallory-Weiss tears, enamel erosion, parotid gland enlargement, and dorsal hand calluses, which we call Russell sign, which I'm highlighting over here. And these are calluses that happen right here on the knuckles because patients self-induce vomiting by sticking their finger down their throat, and in the process, they actually cut their knuckles on their teeth. And this is what's called Russell sign, and this is a high yield physical exam finding that may come up on exam day. In terms of lab findings, we're going to see increased serum amylase, metabolic alkalosis, and decreased chloride and potassium due to repetitive vomiting. And these lab findings can also be found in our binge purge type of anorexia nervosa. So be on the lookout for these lab findings in both of these conditions. In terms of our management, we're going to use psychotherapy and nutritional rehabilitation, very similar to anorexia nervosa, as well as SSRIs. Now, it's usually quite easy to spot a patient with an eating disorder on step one. However, these questions are deceptively tricky, and I always would get a lot of these wrong because they ask about really specific criteria. So I want to highlight the important things here to differentiate these. Important is timeline. Timeline is always going to be really, really important for our psych diagnoses. Additionally, the BMI of less than 18.5, that is hot, hot, and high yield for anorexia nervosa, whereas the BMI tends to be low or normal in patients with bulimia nervosa. So those are some things to really look out for on test day in order to form a differential and knock off potential distractors. Let's move on to talking about binge eating disorder, which is going to be characterized by binge eating food without any compensatory behavior. So we're going to have the absence of purging or other compensatory actions like laxatives, over dieting, over exercising, diuretics. It's important to note that this is what differentiates binge eating disorder from our anorexia or bulimia nervosa, which both have these compensatory actions. So let's talk timeline. Greater than one binge per week for greater than or equal to 3 months. It's important here that we mention timeline in all of our psych diagnoses. It's the most common eating disorder in adults. They love to ask about this. It's also more common in women, just like the rest of our eating disorders. Our management here is going to be psychotherapy, and if we want to move on to pharmacologic therapy, SSRIs are going to be first line, followed by lisdexamfetamine, which is going to be our second line pharmacologic option. Now, let's talk about pica, which is going to be eating of non-food substances such as ice, dirt, or hair. And there are two types of pica. There's psychologically induced pica, and then there's nutritionally deficient induced pica. And it's important to differentiate the two. So in people with psychogenically induced pica, they have some underlying anxiety or discomfort that is relieved when they eat this non-food substance. Whereas those with nutritionally induced pica, they have some sort of underlying nutritional deficiency, and their body interprets eating ice or dirt or hair as a way to relieve that nutritional deficiency. So that's super important to differentiate the two types of pica because that is going to inform our treatment. Pica is also more common in our pediatric and pregnant patients, and like we talked about, it's associated with dysregulated emotions, malnutrition, anemia, specifically iron or zinc deficiency, or lead poisoning. Now, an important physical diagnosis is the presence of spoon-shaped nails. This is going to be indicative of a nutritionally induced pica. So if you have someone with spoon-shaped nails who's also like eating ice or dirt, you may be like, I'm pretty sure this person has a nutritional deficiency. We should check their CBC, see if they have like a microcytic anemia, and see if there's something that's missing in their diet that we can easily replace. Whereas someone who is eating these odd substances to bring emotional relief, that is probably someone with psychogenically induced pica, and they are going to benefit further from psychotherapy as opposed to nutritional rehabilitation. So our management is going to be based on why we think this pica is happening, and that's going to be based on history and physical exam. We can also add on SSRIs as a second line therapy for pica, but in general, it's going to be more important to differentiate if it's nutritional or psychologically induced. So let's just go over a few high yield things. In terms of binge eating disorder, the absence of compensatory behaviors is going to be really important here, as well as our timeline. Also super high yield here is that it is the most common eating disorder in adults and more common in women. In terms of our pica, it's important to differentiate between the fact that it's dysregulated emotions or malnutrition that is causing the pica, and that is going to inform treatment. So I hope this helped you guys out on test day.